and I'm presenting today on Medicaid Managed Care, and would like to go through several slides to help you get a better understanding of Medicaid Managed Care and to understand how it applies to the physician's care practices and also to the individual patients. As we go through the presentation, I just ask that you hold all questions to the end, and we'll have a question and answer session, and also give you my email address if you have any questions further. So let's begin. Medicaid Managed Care is somewhat different from your traditional Medicaid in that it was established to allow states to pay for capitated rates for individual enrollees, and it varies from state to state. Basically what this does is allows these managed care programs to take on some of the additional risks that are involved with making sure that the rates are correct and that each enrollee is provided the proper amount of care according to an actuarial rate established by the governing authorities for each state. And basically what the bottom line is the intent is to decrease costs and to improve care for those who may not have sought care otherwise based on their demographic or information or their risk stratification. And so traditional Medicaid plans have just been a fee-for-service, but the managed care plans have definitely increased over the past 15 years because of this increased costs in care and increase in chronic diseases. And so Medicaid is generally geared towards poor individuals that have socio-demographics based on each state, a threshold set. But under the managed care plans, the patient receives most of their care from these organizations that have contracts with the state. And I'll get into those contracts in a little bit. But overall, 50 million people receive their care via managed care, either voluntarily or mandatorily. There are two types of Medicaid managed care plans. There are commercial managed care plans, and then there are Medicaid dominant HMOs, health maintenance organizations. Pretty much the commercial plans take on Medicaid plans that are less than 75% of the Medicaid enrollees, and they typically fall under a brand or a marketing scheme by commercial payers who typically do traditional health care reimbursement. However, the Medicaid dominant HMO plans include 75 to for 25%, 75 to 100% of the enrollees that are Medicaid beneficiaries. There are three types of Medicaid managed care entities. One is the MCO, which is the most dominant. There are limited benefit plans, and there are also primary care case managers, which are simply gatekeepers that provide referrals to medical services. The one that's most common is the managed care organization, and they agree to pay Medicaid benefits for a monthly fee per enrollee from the state. By 2010, 53% of all Medicaid beneficiaries in 35 of 50 states were covered by these MCOs. And the idea is that the state would pay higher rates based on demographics and chronic diseases, or a combination of both, and therefore lowering the costs according to this data collected by the actuaries. The PCCMs, the gatekeeper type plans, do not account for that many in comparison to the MCOs. As you can see here, there are very few in the United States. The numbers are pretty low. Now, how they determine the rate based on the demographic information is simply, here are some examples of the demographics, age 18 to 45 females that are not disabled, age 45 to 65 males that are disabled. Each one of these types of demographic information would require a different rate, and they pretty much stratify it based on these type of conditions. And that's combined with the risk base. If you take those age stratifications and the gender and then add diabetes or heart diseases, the rates will coincide with those different categorizations. Each state has an option of choosing a Medicaid Managed Care plan, and there are these governing authorities that pretty much mandate what the rules are and what type of rates that they will pay. These authorities allow a state to participate down to the county or a parish if they choose to subdivide those care regions down further than just at the global state level. The comparability of services lets the states provide different benefits to people enrolled at different levels. This is very similar to the Canadian system in that people in the tundra typically don't receive the type of care in a timely fashion that those do in somewhere like Toronto or Quebec. And that statistical data based on demographics and chronic diseases also has a play in what type of plans or levels that these people in certain areas can receive care. In California, for instance, there are multiple levels, and it seems to be growing, the different types of care you can receive under these managed care plans. But there are offered by the state, and the state chooses which level to assign to certain areas. Ultimately, states can pay a company to do this type of subdivision to a company like Humana or an Aetna, and a physician would be enrolled in these type of programs and not even know it. But the state wouldn't absorb as much of the cost if they choose to use one of these MCOs. The governing authority that I just spoke of earlier, there are three types. There's a state plan authority, a waiver authority under Section 1915A and 1915B, and then the third is a waiver authority, Section 1115. And these authorities basically set the protocols for appeals and grievance rights, and they also require quality programs to ensure that physicians that are taking on these patients are providing appropriate quality measures. Inside of the states, we also have comprehensive plans, and as I said before, across the 50 states, there's only 3 states that reportedly did not have a managed care program as of October 2010, overall 36 of the 48 states with managed care plans participated in an MCO, and then 31 were enrolled in a PCCM program. That's according to the Kaiser Foundation. And you can see from this map a distribution of which ones were in MCOs and which ones had PCCMs, and then a combination of both. As you can tell, most of them were in MCO or MCO combination programs. And here's just another graphic to help illustrate that, provided by the Kaiser Foundation. And this information comes from CMS, and it shows how the distribution of managed care enrollment compares in proportion to the Medicaid enrollment overall per state. As you can tell, California has quite a large Medicaid enrollment population, and of that, 55.69% are enrolled in a managed care plan within that Medicaid population. Florida has close to 3 million Medicaid enrollees, and then of that, 83% of them are enrolled in this type of managed care plan. And there are a few others that have well over 1 million Medicaid enrollees, with proportionate enrollees also participating in a managed care plan. It's very interesting to see the percent of states like Kansas where all of the, just about all of the folks enrolled in a Medicaid plan or in a managed care plan. And then here's a concluding state list of all of the states that are involved in managed care within the Medicaid population. Really gives you a sense of the degree of which Medicaid managed care plans exist across all of the Medicaid population. Well over half and close to 3/4 of all Medicaid plans have a Medicaid managed care plan associated. As I said, California has quite a variety of Medicaid managed care plans, and they have 58 counties, 6.6 million beneficiaries, and there are several different types within each one of these regions that each county has the ability to choose to implement in their region. And then Florida they've broken down their plan, Medicaid managed care plan, to have two different types, and that's a managed medical assistance program and a long-term care program. And that was implemented in 2011. One of the big issues that has come up recently is the dual eligible beneficiaries, and CMS has been striving to combine these programs of Medicaid and Medicare, and they've come really close to implementing it. However, one of the issues that comes up time and time again is the fact that these are the poorest and sickest citizens in these communities, and we have to somehow provide care for, get 80% from Medicaid or Medicare. What about the 20% of the fees that are left over? And we accomplish that through Medicaid. so that some of these citizens don't have to pay anything. And this has always caused a sort of a uprising in the political realm because of where we appropriate our funds. And so CMS is trying to solve a little bit of that by proposing capitated managed fee models for these integrated plans and to help reduce the burden on the states. Out of all of the states that have a dual eligible plan, you can see that California has quite a few, and Illinois, Florida, Pennsylvania, New York. All of these plans are geared towards broadening the spectrum of care, but we found that by implementing these dual programs, the patients that were seeing anybody they wanted to see in the past are now limited to a narrow scope of network of physicians. And to that end, we look at the providers who are taking on these Medicaid patients. There has been an increase in commercial enrollees, and that has increased the number of Medicaid plans implemented. And as I said before, some of these providers may be taking on Medicaid patients and not even realize it because they're associated with these plans. In the Medicaid dominant practices, those 75 to 100% that have already accepted Medicaid, they weren't really affected by managed Medicaid, and therefore it really had no effect on their statistics. What we've noticed also in the research is that the providers taking on these Medicaid patients are usually younger male foreign medical graduates where they were more likely to accept Medicaid Managed Care beneficiaries. And there's a decrease in acceptance by board-certified physicians. And so, thus, it has formed a criticism of the quality of care, making some critics question whether or not they're getting appropriate care. Nonetheless, the physicians in the large groups and university settings or employed by hospitals were more likely to accept Medicaid patients under managed care plans. And as more physicians are employed by hospitals, we are definitely seeing a trend and growing more in the Medicaid patient population, which ultimately would improve the quality of care. There are fewer Medicaid managed care patients accepted in markets where there were federally qualified health centers. More of the rural areas were less likely to take the Medicaid managed care plan, which is kind of strange considering it is for the poor people. But that just says that, to me, that the insurers that are associated with these care plans aren't really targeting that demographic. And generally speaking, the fees increase in areas where MCO was implemented that had already had Medicaid services in the past, and that's due to the additional marketing by some of these plans that go under the umbrella of a large insurer. Some providers are operating under the confines of the Medicaid Managed Care Agreement, and they don't even realize that I said that 3 times. Just wanted to really pound that point in because it is important. So what would this do to the patient? Patients have been pushed over to managed care plans and told that you can keep your doctor for 20 years in the past. But now there are such restrictions that the provider network is narrowed and it somewhat decreases the options. So in the past, we would have said switch now, but states are leaning towards sticking to the provider and hoping that legislation will continue to allow them to stick with their doctor instead of switching later. So some final discussion points are around what this does to the healthcare community where you are. And we're seeing that there's an increase in emergency department utilization, decreased outpatient acute care and surgery. Physicians aren't encouraged to implement MCOs, but the Medicaid patient population does increase already in the network. Most states use take a use it or lose it, take it or leave it approach. Sorry, and that means that you can take what we get or just totally ignore the Medicaid population. In such cases, the rates for each cohort and others negotiate individually with prospective MCOs. And so there's a constant lobbying by the physicians to negotiate fee schedules, even for the Medicaid patients. States may need to increase reimbursement, decrease administrative costs, and revise contracts to include incentives to reduce costs for those low-income patients. That is true for all of the quality programs and for all of the programs that want to increase the quality but decrease costs. It seems as though the incentives are the only way to really get people to do that. I've included a list of references. Feel free to ping me or question me about any of these facts that I've presented. And now I'd like to open up the floor for discussion. If I haven't woken you up, put you to sleep.
Okay, let's see. Or should be here, yeah. Okay.
Hello? All right, well, that concludes today's session. My email is roy.hightower@quirkhealthcare.com. If you have any more concerns that you just don't feel comfortable sharing with the group. And I look forward to hearing from you all, and hope you have a great day.